Hello, I'm Kate Kendell, consultant clinical psychologist at the Northern Centre for Cancer Care in Newcastle, and I'm really delighted today to be doing this talk for Live Well with Cancer. Thank you very much. This first slide is a really simple way of illustrating how many people find their experience of cancer. So we're all on a life path with our background behind us, our sense of who we are, and a sense of where we're going in life and what the future might hold. And then a very, very difficult experience can come along, an unexpected traumatic experience, like a diagnosis of cancer, and that blows your whole world apart, blows up the life path. And usually that's a time of great shock, and very quickly people are on a treatment path, being told what to do, and things are quite mapped out. And often people describe that period of being on automatic pilot. And at some point when your treatment ends, often people are told, go off and get on with your life now. But that can be more tricky than it sounds, because it feels as if the path's not there anymore. And people have to discover a new path, a new normal. And sometimes there's very difficult things on that path. There's changes that are very unwelcome. But also there can be good things that come out of the new normal. So it can also be a hopeful time and a time to reset. So this is a model from two colleagues, Maury and Greer, and they describe how cancer can be seen as two threats. So the first threat is the threat to survival. Usually when someone's diagnosed with cancer, the immediate thought is, am I going to live? Is this going to kill me? How long have I got? And that is the threat to survival and can feel very, very scary. Over time, often people realize that the threat to survival might not be as great as they had first feared. But then other threats come in, what we call the threat to self. And that can include things like body image distress. It can be changes to lifestyle, changes to your roles and things that you're able to do. It can be changes to finance. It can be any area of life that's affected by the diagnosis and treatment for cancer. And for many people, the threat to the self is actually greater than the threat to survival. We all process everything that's going on for us every day. And somebody with a diagnosis of cancer has to process what is the threat to survival and what is the threat to self. And they come up with beliefs about what that means. And those beliefs and what they believe about the threat to survival and the threat to self then affects coping, the response in terms of behaviour, cognition or thinking, and also the emotional response. So Maury and Greer also talk about what they call the personal meaning of cancer. For most people, a diagnosis of cancer is a very unwelcome event in their lives, but it is different for everybody. It means different things to different people, and that's why we talk about the personal meaning of cancer. And what we mean by this is, what does this cancer mean about me, my world, and my future? And when I'm working with people clinically, that is what I really want to find out for them. What does this cancer mean to you? And then that guides us with the best way to help. Psychologists love models, so here's another model. And this is a very old model, but it helps us understand about adjustment being a process. Adjusting to a diagnosis of cancer is not a one-off event. It's something that we go through over time. So first of all, after the diagnosis, somebody has to think about what is this threat, and process all the thoughts and all the feelings that go with that threat. And then the next bit of adjustment is actually considering, what capacity do I have to cope? And the processing of those two questions then leads to coping response, and that can be either helpful or unhelpful. We all have coping strategies. Whether or not we think consciously about our coping strategies, we all have strategies that we use in difficult situations. So if you just take a moment now, I'm sure that all of you watching and listening can think about what your own personal coping strategies are. What have you found helpful so far in dealing with your diagnosis? And what have you found helpful with previous difficult issues in your life? Here are some things that have come up from other people with a diagnosis of cancer and from the research. Being in touch with your thoughts and emotions is very important. Acknowledging what you're thinking, what's going through your mind, and acknowledging how that is affecting you emotionally. And usually that's a whole range of different emotions. Being able to problem solve, so to think about things, but to be moving forward with thinking and thinking about, is there anything at all about this that I can do something about? Breaking down the problem into chunks and thinking about different aspects of the problem and considering if there's anything at all that you can do that will make a difference. Being able to accept support, that's very, very important. And that can be the support of professional people taking care of you, but also of family and friends. Exercise is very important, and I think you're going to have access to another talk by Matty about the importance of exercise and how important that is for both physical and psychological well-being. Valued, meaningful activities is very, very important for all of us at any time in our lives. And we often have to adapt those things depending on the circumstances we're in at any point in our life. But to be engaging in things that are really important to us and valuable to us and connect with a sense of who we are and who we want to be is very, very important. Communication is, again, incredibly important. And again, that involves communicating with healthcare professionals, but also with your loved ones. And it's something that can often be quite difficult after a diagnosis of cancer, because often loved ones want to protect each other and might hold off saying how they're feeling in order to protect the other person. But whether you're a patient with cancer or a loved one of somebody with cancer, actually being able to share about how you're feeling and thinking and talking about that with the other person is really important. So unhelpful coping, usually in our repertoires of coping, we have some unhelpful coping things as well. And maybe again, you can take a moment to think, is there anything that you tend to turn to when you're experiencing a stressful time in your life that actually is counterproductive or not very helpful? So again, some things that have come up from other patients with cancer, but also the research, are denial. So we talk about denial. Usually it's not extreme denial. There's not that many people who deny completely that they have a diagnosis of cancer, but it can be lower levels of denial of or avoiding being in touch with feelings, being in touch with thoughts, denying the impact that the diagnosis and treatment is having on you. Suppressing thoughts and feelings, trying to squash things down, pretend they aren't happening, carrying on as if nothing's happening, just putting on a brave face. It's not generally very helpful. Rumination, and by that I mean thinking that is going round and round in circles, just in a loop, going round and round, thinking about the same things, dwelling on things, but not being able to move forward. So that's really the opposite to the problem solving that we talked about. That was helpful coping, when you're thinking about something but moving forward with it. Rumination is going round in circles with your thinking. Giving up valued activities is unhelpful, because they're very, very important to a sense of who you are. Alcohol is a very, very common coping strategy, and that counts for patients as well as healthcare professionals, but it is not a helpful coping strategy. In the longer term, it is very detrimental to both physical and psychological well-being. So using alcohol as a coping strategy is not a good one. And too much Dr. Google. Again, it's very, very tempting when somebody's ill to go on the internet, to search for things, to search for patient stories, to search for alternative treatments and cures. But we know that by going on the internet, you're accessing all sorts of different things. Some of it might be good and helpful, but a lot of it might be anecdotal, have no evidence base to it, and actually be counterproductive. And for some people, they get quite addicted to and spend huge amounts of time on the internet searching for things to do with their cancer. And that's generally associated with poor outcome and very high levels of anxiety. So your healthcare professionals are the very best people to know about your cancer and your treatment. And they can also recommend good sites where you can get good information that is evidence-based and helpful. So ultimately, when someone has a diagnosis of cancer and are going through treatment, there is 2 jobs to do. One of them is to actually give yourself time to think all your thoughts and feel all your feelings and do the processing that is needed in order to make an adjustment and to accommodate this great change in your life. But the other equally important job is to get on with normal daily activities and to do the things that are nothing to do with cancer, that are about you and your life and what's important to you. And that might be going on the beach and walking your dogs, but it might be something very different for you. It's personal, and the important thing is what's important to you as an individual. One problem that is very, very commonly experienced after a diagnosis of cancer, so common that I would say it's almost universal, is fear of recurrence. And we could also call this fear of the future. And this affects most people, the great majority of people with a diagnosis of cancer, to some degree or another. And it can be very disabling, and in extreme forms can really prevent people, hamper people from getting on with their lives. Again, this is another model of health anxiety, and health anxiety, like fear of recurrence, they're like close siblings. They go hand in hand with each other. And this is a model of how health anxiety can affect us. So it usually starts with a trigger. So say, for example, somebody with a diagnosis of, say, breast cancer might wake up one morning and notice that they've got a headache. So that could be the trigger. And this immediately can give a sense of threat, which leads to apprehension, to worrying. And once you're worrying about it, there's going to be a great focus on the body, really noticing and dwelling on and focusing on the thing that feels wrong, the headache, and other parts of the body. And this in turn kicks in the fight or flight response, which gives physiological arousal. So you might notice things like your heart thumping, butterflies in your stomach, feeling sweaty, shaky, and all that is entirely harmless, but it makes you feel very unwell and adds to the sense that there's something wrong. And the other common thing is checking. So you might keep checking, how bad is my headache? Maybe even prodding your head, feeling your temples, feeling for lumps. And also to seek reassurance, might be asking friends, loved ones, going on the internet, phoning your GP, phoning your healthcare professionals to seek reassurance about what this headache might mean. All these things lead to a great preoccupation with the idea that something is wrong, that something is abnormal, and then jumping to the conclusion that this must be a sign of serious illness. So, for example, someone might conclude that this must be a brain tumour. And that is probably not something that that individual would have thought of before they had a diagnosis of cancer. They might have thought, oh, I didn't sleep very well last night, or I had one too many glasses of wine, or I'm in a stressful situation. But once you have a diagnosis of cancer, it's very common to interpret any other signs or symptoms that you're getting in your body as a sign of further cancer or something else serious. So in terms of distress, distress is normal. We all experience distress at different times in our life. We all experience a whole range of emotions: anxiety, anger, sadness, as well as joy and pleasure and contentment. But In any situation, there is a continuum of distress. So in cancer care, we expect that there is going to be some time-limited distress. That's entirely normal. At the point of diagnosis, most people have some level of upset and distress, and that can go on for several weeks as somebody makes sense of their new situation. Further up the continuum, if we think that the distress is starting to interfere in somebody's life so that they're not able to get back on with normal life, then we call that clinically relevant distress. And at the other end of the spectrum, people can suffer a distress that is common enough, that is severe enough to warrant a formal diagnosis of anxiety or depression or another psychological disorder. And that is still common, but that is at a level where someone should seek some professional help. So in terms of professional help, this is a model from the NICE guidance, which is about the recommended levels of psychological support that should be available to people with a diagnosis of cancer. So this should be available to all adults with a diagnosis of cancer, depending on their needs at the time. So at level 1, this applies to all healthcare professionals. All healthcare professionals looking after you should be able to recognise the importance of psychological needs. They should be capable of giving effective information and compassionate communication and a general level of support. At level 2, we're talking about healthcare professionals with additional expertise and training, and they are able to screen for psychological distress and use psychological techniques in their day-to-day work, in the other things that they're doing with you, that are going to be supportive and helpful. Very often these people are clinical nurse specialists, but they can be any profession who have gone through the level 2 training in order to enable them to use these skills. At level 3, we're talking about people who've got further training and accreditation in a specific therapeutic model. And the difference here is that someone is going to be solely there to provide you with some psychological support. So it usually involves a referral to somebody with expertise. And an example of this would be going for counselling. So where you would be referred to a counsellor and see someone who's going to focus solely on your psychological needs. Then at level 4, we're talking about mental health professionals. So clinical psychologists like myself and my colleagues, and in some areas, liaison psychiatrists. And these are people who are trained in working with people with mental health difficulties, with formal diagnoses of depression and anxiety, and with higher levels of distress. We've talked quite a bit about the difficulties that can arise out of a diagnosis and treatment for cancer. But as we said right at the beginning, when we looked at the survival model, there are very good things that can come out of a diagnosis of cancer. There are silver linings. There are very, very few people, in fact only one person that I can think of in my clinical career who was actually pleased to have a diagnosis of cancer, but that is very rare. For most people it's a negative, difficult life event. But good things can also come out of it. And we call this post-traumatic growth, when somebody has been through a traumatic experience but finds good things come out of it and can grow as a result of it. So examples of post-traumatic growth are a renewed sense of purpose in life, greater appreciation of family and friends, a chance to review priorities, and often this is about work-life balance, and things that might not have been prioritised before, which suddenly seem more important. Also a motivation to resolve long-standing problems, and an overall determination to live life to the full. Some people talk about this has been a wake-up call, or this has given me a second chance, and for some people that's a very positive experience. I want to share with you now a couple of case studies based on people that I've worked with who've been referred to me. I have changed their details so that they remain anonymous and this is confidential, but these are stories that I would like to share with you. So Jed was a 60-year-old man who was referred to me about 12 months after his diagnosis and treatment for prostate cancer. Jed had been on hormone treatment He had been through radiotherapy and he was continuing with the hormone treatment after his radiotherapy. He had been deemed well enough to carry on and get on with his life, and he had gone back to work in his full-time role as an assistant manager in a very large supermarket. But he was struggling to stay at work. He was struggling with the work and feeling very, very distressed. He had also disengaged from all his normally enjoyed activities. He felt distant from his daughter and his wife, and he had not picked up his hobbies again of gardening and coaching a local junior football league. So his family were worried about him, the healthcare professionals looking after him were worried about him, and his clinical nurse specialist, who had done some psychological screening, referred him to clinical psychology. So when I assessed Jed, what became apparent very quickly was that he was very, very distressed about his sister, who had died 5 years previously at the age of 60, the age that Jed was now. And he had been very, very close to his sister. He had been involved in helping to care for her when she was very ill at the end. And these images were very stuck in his mind. And he had ideas and the belief that his cancer was going to progress very, very quickly, and that his deterioration was going to follow the same pattern as his sister's. And he was having very upsetting thoughts like, I'm never going to see my daughter get married, I'm never going to see my grandchild, I'm never going to be a grandfather. So he was highly distressed, but was very happy to engage in a psychological therapy because he wanted things to be better. So the first thing we did was we used some techniques from cognitive behavioural therapy to help him to see the difference between his sister's situation and his own situation, to see that just because both of the illnesses had the label cancer, it didn't mean that his path with cancer was going to follow exactly the same path as her path with cancer. And we looked at things from a very rational perspective. We looked at the evidence about what his doctors were saying about him, about his diagnosis, his prognosis, what he'd been told, what his latest health tests were showing. And he was able to see logically that his situation was very different to his sister's situation, and they were very different diagnoses. So he got it logically, and that helped to a certain extent, but emotionally he still felt very distressed. And it was clear that he hadn't really ever resolved the death of his sister, and he was still grieving for her. So we then went on to use some more techniques from eye movement desensitization and reprocessing therapy. And this enabled Jed to process the grief that he felt for his sister and to experience all the thoughts and feelings that he needed to in order to move on. And that gave him an awareness at a more emotional level that his situation was different to his sister's. And he was able to be in touch with all the thoughts and feelings that he needed to be, and felt much, much better by the end of that. Then the final piece of work that I did with Jed was using techniques from acceptance and commitment therapy, sometimes called ACT for short. And this was about engaging with Jed to help him to make a commitment to re-engage with important parts of his life, not to wait to feel completely better before he started taking up the things that were important to him, to make that commitment to get on and act and do the things that he needed to do rather than wait to feel completely better first. So he started very, very gradually with picking up some gardening again, just doing an hour or so a week. And he also made a commitment to start visiting his daughter again and going out with her or visiting her once a week. And that was really important because they had been very, very close, and she'd been quite distressed by the fact that he'd disengaged from her and wasn't spending time with her. And then as Jed began to feel better and to really, really benefit from re-engaging in his life, he made some bigger decisions, and he went back to watch the football team that he used to do the coaching for, and then he moved gradually into being a linesman again, with a view to one day picking up the coaching. And then Jed made some bigger decisions about his work. He had managed to go back part-time after going back full-time, struggling, being on sick leave again. He then went back gradually into a part-time role. And after several months in the part-time role, he made the decision that he wanted a different work-life balance. And so he made a decision to actually be part-time permanently. And that freed up 2 days a week for him, one in which he decided he was going to get an allotment, and the other day a week he made a commitment to help his wife look after their grandchild who had by then been born. So that was Jed's story, and he did very well with psychological therapy. Sam is another patient that I would like to tell you something about. Sam was a woman with breast cancer. She was age 38, and she had been through treatment for breast cancer, which she had found very, very grueling. At the time that she was diagnosed, at the time that she was referred to me, she was highly distressed, was spending most of her time sat at home on her own, going round and round in circles, ruminating about her experience. And she was absolutely crippled by fear of recurrence. She was so sure that she was going to die of her cancer, and that would be something that she couldn't possibly accept, that she was actually contemplating suicide as a way out of that. And she was indeed quite a high suicide risk, so everybody was very worried about her. But she agreed to engage in a psychological therapy. And at assessment, it was clear that there was many things wrong for Sam. She had had a very, very difficult life. And before she was ever diagnosed with cancer, she had had a very difficult childhood and early adulthood, full of a series of traumatic experiences. And her current situation was that she was living in an abusive relationship, and she was isolated from friends. So there were lots of things that weren't right for Sam, but we started very, very gradually for her, getting her to re-engage in some meaningful activities. And for Sam, she chose her bike. So riding her bike was something that had been very important to her, but the bike had been shut away in the shed for months and months and months, and she couldn't bear the thought of being out on her bike again. But she did make the commitment to give it a go. So the first step was that she was to take the bike to be serviced and get it safe and roadworthy again. And then she was to ride the bike round the block just once before she saw me again. And she did that, and then she gradually began to extend her bike journeys. She would go to the local park, and then eventually she rode out to the coast, and she began really, really enjoying riding her bike again, so she was going out regularly. Then one day she was at her local hospice having some treatment for her lymphedema, and she saw a poster which was about a charity bike ride, which was something she'd never ever done before. But she was interested in this, and she asked the staff about it, and she signed up for this local charity bike ride. And then she got quite excited about getting sponsorship, and she ended up raising quite a lot of money for the hospice. And this really gave her the bug, and she started then looking for more charity bike rides. And she, over the next few years, she did many bike rides, and she got very engaged in raising money. She raised a very significant amount of money for local and national charities, and she also met a whole new circle of friends, and this led to her a much better self-esteem, much greater confidence, and an enjoyment of life that she hadn't felt in a very, very long time. As she got the confidence with meeting new friends and being around different people, that also gave her the confidence to get out of the abusive relationship and to realise that she could live independently on her own, and she didn't need that relationship. So for Sam, many positive things came out of this. And although she would never have said that she would have welcomed a diagnosis of cancer, it was still a very difficult thing in her life. She was able to acknowledge that the experiences that she'd had with raising money and in finding new friendships and even getting some press coverage from local newspapers were things that she would never have done in her life if it hadn't been for the diagnosis of cancer. So that is a very nice example of post-traumatic growth and positive experiences coming out of a difficult situation. Before I finish, I just want to go through one really good coping technique with you. This is a technique that comes from Russ Harris's book, The Happiness Trap, and it is quite a simple breathing exercise, and it also might be seen as a simple form of mindfulness. And this is something that any of us can do at any time, that can be really, really helpful. It's something that I share with a lot of patients, and it is something that I use myself every day and find very helpful. So to breathe in through your nose slowly and deeply, and then to hold the breath for a couple of counts, and then to breathe out slowly and fully out of your mouth. When you get good practice at that, you can move on to this 12 breath exercise. So the 12 breath exercise is when you take 3 of those slow, deep breaths in through your nose and out through your mouth, and just focus solely on those breaths. Then the next 3 breaths you can build in noticing what you are thinking, what's going through your mind. And that is just to notice what's going through your mind, not to judge it, just to notice it and let it be. Then for the next 3 breaths, you notice what you're feeling. So what are you feeling in your body? Just notice those physical sensations. Just scan the body and notice anything that you're feeling. You don't need to judge those feelings, just notice them and let them be. And also notice your emotional feelings. How are you feeling in yourself? That might be a range of different things. It doesn't matter what they are, just notice them and let them be. And then finally, for the final 3 breaths, just notice your environment. Notice your environment using all your senses. What can you see? What can you hear? What can you smell? What can you taste? What can you feel against your skin? And just notice that and let it be. I find this exercise really, really helpful. I do it at least twice a day, and many of my patients find it really, really helpful. And one of my patients said it was like pressing the reset button, and he used it several times a day and found it very helpful. And it can be used really at any time and any place, and no one needs to know you're doing it. It's a very private thing, and you don't need any special equipment or gadgets or apps for it. It's just something you can do just in your own time. Thank you very much.